Okay, so I think I will go ahead and start. Welcome everybody to this online webinar organised by the World Federation of Societies of Anaesthesiologists, a webinar on unrelieved cancer pain. Thank you all very much for attending, and we hope you enjoy the event. This webinar has been organised, as I said, by Dr. Gauhar Afshan and the Pain Management Committee of the World Federation of Society of Anaesthesiologists, the WFSA. My name is Clare Roques and I am the chair of this Pain Management Committee, and I'm based in Windsor in the UK. Before we introduce the panel of today's webinar, we have a couple of technical formalities. First of all, the meeting is being recorded and it will be available afterwards. Everybody aside from our panellists and speakers are automatically on mute today and all cameras are off. If you have any questions or problems hearing us or seeing us, please use the Q&A function to send over a message. Some of you are joining us from Spanish-speaking countries, and to ensure that you hear today's discussions in the correct language, please can everyone, including the English listeners, head to the interpretation globe at the bottom of your Zoom screen, or in the top right-hand 3 dots if you're on a phone, and select English or Spanish. Presenters, can I ask you to speak clearly and at an appropriate pace? And we also ask you to keep yourselves on mute unless you're being asked a question, and to turn your camera off if you're not actively involved in this section of the webinar. The session overall will be a 90-minute event. We'll start with a presentation giving us an overview of the current state of cancer pain, and then move on to a panel discussion with an opportunity for you to ask our panelists any questions you may have. So please feel free to send over questions you have in the Q&A function at the bottom of your screen. Do that at any point as the session goes along, and we'll answer as many questions as we can. After the session, we'll be sending you a request for feedback, and we will also send you an email confirming that you have attended the event. Thank you very much again, and I'll now hand over to Dr. Gauhar to introduce herself and the rest of the programme.
And thank you very much. You may know that WFSA has chosen anesthesia and cancer care is the theme for the year. And considering this, the theme, that is anesthesia and cancer care of WFSA, the Pain Management Committee of WFSA has planned a series of webinars on cancer pain. And today is the first of the webinar of the 3 series. And you know, the theme of this is Unrelieved Cancer Pain, a Global Crisis. As Claire just mentioned, that we have a program starting with the state-of-art lecture, and we are very fortunate to have today Professor Ateeq-ur-Rehma. And Professor Ateeq-ur-Rehma will talk about the inadequately relieved cancer pain, the medical and moral imperatives to respond. A very attractive title. And it would be followed by a moderated panel discussion. And the moderator of our session is Dr. Ateeq-ur-Rehma. And we have 4 very well-known panelists. Dr. Ateeq will introduce all of them. So it's my pleasure to start the first introduction. And this is introduction of Professor Ateeq. Professor Ateeq is a director of the program in the Global Palliative Care, and he is Associate Professor, Harvard Medical School, and a consultant in palliative care, Massachusetts General Hospital, Boston, USA. He is also the honorary chair of the Department of Palliative Care at the University of Medicine and Pharmacy in Vietnam. He's also the former medical officer for palliative care at the World Health Organization. He has a lot of research and publication, and he is authority in this area. And we are very pleased to have today in this webinar. So please, Professor Ateeq.
Thank you so much, Dr. Gauhar Afshan, and thanks also Dr. Clare Roques and the leaders of the World Federation of Societies of Anesthesiology. It's a great pleasure to be with you to talk about this important topic. And in fact, I think that collaboration between palliative care specialists like me and anesthesiologists is absolutely crucial, and we could do more and more in that area. So I've made a slight change in the title, relieving cancer, pain, medical, moral, and financial imperatives, since there is data also on the financial benefit of palliative care in general and relieving cancer pain specifically, and that tends to get the attention of ministries of health. I always like to start with the patient because this is why we're here today, I think. I have no conflicts of interest. So by the end of this short talk, I hope that participants will be able to discuss the prevalence of untreated pain and other types of suffering due to cancer and other serious illnesses, to describe the WHO guidance on responding to cancer pain and other types of serious illness-related suffering, and to discuss how anesthesiologists can reduce the prevalence, duration, and severity of cancer pain and other types of suffering. So I'll begin by talking about how to measure the global burden of pain and other serious illness-related suffering. And this is based on work I did as a member of the Lancet Commission on Pain Relief and Palliative Care, published in 2018 and available online. A kind of a summary of that work was also published by the World Bank in its publication called Disease Control Priorities, which is designed to advise and guide ministries of health around the world on how best to spend their funds. And the final volume, the volume 9, which is the one in which the palliative care and pain control chapter appeared, is the highest priority interventions, also available online for free. So I will begin by showing the enormous disparity in access to opioids among people with serious illness-related suffering. So this is not a very accurate way of showing access to palliative care or even access to cancer pain relief, but it's a sort of a surrogate measure because we have the data. So the denominator here is people with serious illness-related suffering, not just cancer pain, but people with any serious illness and related suffering. And the numerator is the milligrams per year, and this was 2015, of oral morphine equivalents. And I assume I don't have to explain what oral morphine equivalence is. Any opioid converted to oral morphine. So in Canada, a patient with some type of serious illness-related suffering, and I'll explain what I mean by that a little in a few moments. So any patient with any serious illness and related suffering used on average 68,000 milligrams per year of oral morphine equivalents in 2015. And the size of the country is keyed to the milligrams of oral morphine equivalents per patient. So you see that Canada is very bloated, the US, Australia, less so Western Europe. Where is South Asia? Where is China? Where is Russia? Where is Africa? Almost invisible. So again in 2015, looking, for example, at India, 43 milligrams per year of oral morphine equivalents per patient with serious illness-related suffering. So it's barely a day and a half of a starting dose of oral morphine. So enormous disparity. Okay, so why is all this? Why is there this enormous disparity? So we talk in palliative care about opiophobia, fear of opioids, and this is widespread among political and healthcare leaders. Everything is based on policy, and if the policies aren't in place to enable rational, safe opioid prescription and opioid therapy, it won't happen. There are very highly restrictive laws and regulations on opioids, such as requirements for licensing or permission to prescribe, that are overly restrictive, complicated prescribing forms, restrictive rules for pharmacies, explicit or implicit threats of punishment or even arrest for clinicians who prescribe opioids, lack of training in opioid analgesia throughout healthcare education. Among clinicians, doctors don't prescribe, nurses are afraid to administer opioids, sometimes even when they're prescribed. Pharmacists don't stock opioids. And many patients don't even complain of pain. I can't tell you how many times in my career I've encountered patients who with cancer pain, which was obviously severe, and they didn't complain. Why? Because they've never seen anybody get relief. So why complain about something when there's nothing, then there's no expectation that anything could be done about it. And then, of course, there's also people who are afraid of opioids, either because they're afraid of addiction or because they're afraid it means that they're dying. This is just an example from one country, Vietnam, of the kind of red tape that patients have to go through to get a prescription. So a special form with a stamp required not only by the prescribing physician, but also by an anesthesiologist. So someone has to go track down an anesthesiologist, and a stamp from the director of the hospital. So how feasible is that for a patient or a family member to get all those stamps? So this leads to a sort of vicious circle. There's low opioid consumption in hospitals and in a country. So every country, by an international agreement called the 1961 Single Convention on Narcotic Drugs, that every country has signed, basically, every country is required to report opioid consumption per annum, and also then estimate the need for the following year. And usually the estimates are just based on the consumption from the previous year. So they're very low estimates of opioid need that are reported to the UN agency called the National Narcotics Control Board that sits in Vienna. So little opioid is allocated to the country. There's little opioid produced or imported. So again, there's low consumption, and it just goes around and around like that. What are the sequelae? Well, I think you know the sequelae very well. The sequelae of untreated acute or chronic pain, mood disorders like post-traumatic stress disorder, anxiety disorders, impaired sleep, demoralization, major depression, and of course, impaired functional status. There's also data on that I'm sure you know well on on sequelae of untreated or inadequately treated acute and post-op pain, such as cardiovascular side effects, arrhythmias, MI, myocardial infarction, congestive heart failure, stroke, deep vein thrombosis with pulmonary embolism, atelectasis and pneumonia, because patients don't expand their chest if it's painful, hypercatabolic state, tissue wasting, compromised immune function, and then development of persistent chronic pain. Actually, there was just a paper this week published in one of the journals that showed that patients who received intraoperative opioids were much less likely to develop chronic pain and needed less opioids in the post-op period. And of course, then there are also increased costs for patients in the healthcare system when these complications, sequelae occur. And most importantly, there's the suffering of our patients, the unnecessary suffering of our patients. And I would just add that in patients with cancers like the woman I met in Haiti in the photo on the bottom right, any patient with a tumor that size, especially in a highly innervated place like the face, is going to have at least partially neuropathic pain. And then looking at the bottom left, a patient with end-stage COPD, chronic obstructive pulmonary disease, opioids are also crucial for treating dyspnea that's refractory to other treatments, very common in patients with end-stage cancers. In 2014, almost 10 years ago, the World Health Assembly, which is the governing body of the World Health Association, resolved with the unanimous agreement of every Minister of Health of the 194 member states of WHO. There was a resolution that it's the ethical duty of healthcare professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual, irrespective of whether the disease or condition can be cured. It also resolved that PC, palliative care, and you could also say pain control, but pain control and palliative care is an ethical responsibility of health systems, not something that's optional. It's an ethical responsibility, and efforts to minimize risk of diversion of controlled medicines for illicit purposes must, quote, not result in inappropriate regulatory barriers to medical access to such medicines. And these regulatory barriers, unfortunately, still persist all over the world, as I'm sure you know well. Okay, so what did we do on the Lancet Commission? We endeavored to estimate the global burden of illness-related suffering. So the first we identified the serious conditions in the International Classification of Diseases that most commonly result in physical, psychological, social, or spiritual suffering. And we distinguished between two populations of patients. Decedents are those with serious illness-related suffering from one of those conditions who died in 2015. And non-decedents is the patients who had one of those conditions and associated suffering, but did not die in 2015. And these are the numbers that we came up with. So in the middle column, the decedents, we see, for example, that there were about 7.5 million people who died of malignant neoplasms in 2015 who had serious illness-related suffering. Another 7 million who had cancer and serious suffering related to it, but did not die in that year. So almost 15 million people who had serious illness-related suffering due to malignant neoplasms. And this is also the list of the 20 or 21 conditions that generate, we estimated, about 95% of the need for palliative care. Down toward the bottom, I'd call your attention to injury, poisoning, and external causes, also a major cause of serious illness-related suffering. Untreated illnesses, trauma, long bone fractures, patients getting no analgesia in the emergency department, and inadequate post-op analgesia, very common. And then a lot of pain associated with some of these other conditions. This is all available in the Lancet Commission report. We then determined the categories and specific types of suffering resulting from each condition, the prevalence of each type of suffering, and the duration. And this was based on literature review and expert panel of physicians, mostly from low and middle income countries. These are the 4 categories of suffering: physical, psychological, social, and spiritual, and the specific types of suffering in each category. And I'll focus for this talk on moderate and severe pain and on dyspnea, marked in red. But of course, there are many related conditions, the constipation associated with opioids, all of the other types of suffering that tend to occur along with pain, particularly psychological distress. And this slide just shows a little bit more detail. This is only patients with cancer, with serious illness-related suffering due to cancer. So in the middle column under decedents, we see again that there were 7.5 million patients with cancer with serious illness-related suffering. 80% of them, or 6 million, had moderate or severe pain for, on average, 90 days. That information is in the red row. And then among non-decedents, patients with cancer, the 7.1 million who had cancer and serious illness-related suffering, 20% of them, by our estimate, had moderate or severe pain for an average 90 days. And then the numbers for dyspnea are just below that. 35% of the decedents had a moderate or severe dyspnea for an average 90 days. And I would just add that at the very end of life, cancer patients vary, whether it's the last minutes or hours or days, very many patients develop dyspnea that's refractory to diuresis or bronchodilators, the usual efforts, oxygen to relieve dyspnea, and opioids are very effective. So we use this method to calculate opioid need for patients with serious illnesses, but this needs to be adjusted, of course, for the opioid requirements for intraoperative care, postoperative care, critical care, and for treatment of opioid use disorders with methadone and buprenorphine. But to help assure that patients with medical need for opioid receive it, again, I'll just emphasize the importance of national policies on opioids that strike a balance. And this is the important concept from the 1961 Single Convention on Narcotic Drugs. A balance between maximizing access for medical uses and minimizing the risk of diversion to non-medical uses. Unfortunately, it's the latter that gets most attention. And then training needs to be provided really for all doctors and all nurses and healthcare professionals in pain control. I see that time is running short. I'll move quickly. There's no dichotomy between palliative care and pain control and disease-modifying therapies. In fact, chemotherapy and radiation can often relieve pain. By treating pain and other suffering, patients are able to adhere to their cancer treatment. So therefore, pain control and palliative care really need to be integrated with cancer treatment. And if we're not doing that, we're not fulfilling patients' human right to attainment of the highest possible state of well-being. I'll finish just by going briefly through the essential package of palliative care that's recommended by WHO and an augmented package. And I do this, and perhaps this could be a question for the discussion. I do this because I think in many places, if anesthesiologists don't provide pain control and even more comprehensive palliative care, no one will. Anesthesiologists are very well placed to do that. So the essential package of palliative care includes interventions, medicines, equipment, social supports, human resource, the trained human resources, and includes standard operating procedures, all of which we've costed and found that it's feasible to be covered by public health insurance in any setting. These are the interventions, prevention and relief of all these types of suffering. The medicines list is based on the WHO model list, but it's boiled down to the most essential medicines that are most available on the world market and inexpensive. This is the list, and most importantly, it includes oral immediate release morphine and injectable morphine, but also amitriptyline for neuropathic pain and dexamethasone, bisacodyl to treat the associated constipation, and also just mention a selective serotonin reuptake inhibitor for treating depression, haloperidol for delirium, and also as an anxiolytic. The equipment, opioid lock boxes, very important. A lock box attached to something unmovable like a wall to keep the opioid safe, prevent diversion. Often the essential package of palliative care is enough to take care of a high percentage of the need of serious illness-related suffering. But there are, of course, patients whose suffering is refractory to basic palliative care, particularly patients with certain cancers, cervical cancer, head and neck cancers, for example, where there's tumor invasion of nerves, tumor invasion of vasculature causing massive hemorrhage, GI obstruction, fistula, incontinence, and of course, there's also financial toxicity. So for that reason, there needs to be an augmented package of palliative care, which includes all these items, and most importantly for this audience, neurolytic procedures for relief of severe or refractory pain, as well as additional medicines such as sustained release morphine, fentanyl transdermal patches, fentanyl injection, lidocaine injection and ketamine, oral and injectable. Methadone, we tend to exclude because it's complicated and we worry about people who are inexperienced using it and getting into trouble, and also because it's very much needed for treating of opioid use disorders. And finally, then the nerve blocks, so important, can be so helpful. So for example, on work I did with WHO on cervical cancer, patients with pelvic pain can get such good relief from superior hypogastric plexus block, ganglion impar block. Intrathecal therapy also can be so important. And then neurosurgical procedures, although relatively rare, but can be very helpful for the most refractory pain. I'll stop there and just emphasize once again how important I think it is for palliative care and anesthesia pain specialists to work together and collaborate. We're all aiming for the same thing. Thank you so much.
So thank you very much, Professor Ateeq-ur-Rehma. Thank you very much for a highly informative your talk, especially with a very alarming statistics, very, very alarming statistics you share with us. And certainly the issue which you raised it for the future collaboration, our society and of course our pain management committee would look into it. Thank you very much again. So before any further delay, because we are on time actually. So I would request for in the next session, which is a moderated panel discussion. And for this, I would request Dr. Ateeq-ur-Rehma Gauhar, who is the moderator for this, panel. Dr. Ateeq is a consultant in pain medicine and anesthesia. He completed his training in anesthesia and pain medicine in Republic of Ireland. He is one of the very few qualified pain physicians, academic physician in Pakistan. He's extensively involved in teaching and training of pain medicine in Pakistan and currently the lead of the pain services in one of the leading hospitals of Lahore. He has a special interest in spinal pain, cancer pain, and neuromodulation. So Ateeq, please hand over to you now for the panel discussion.
Thank you very much, Dr. Gauhar, for the kind introduction. I'm very grateful to all those who have joined us from the various parts of the world. And it's really sad to see the incidence of the unrelieved cancer pain in this modern era, especially in the developing part of the world. So today we are going to discuss why it has been left untreated, unrelieved, and what we can do as a physician to relieve this misery. So I have 4 panelists with me from the various parts of the world. They're all very prominent in the field of the pain medicine. I'll give you a brief introduction of the panelists and then we will start with the discussion. So first of all, Dr. Ashok Kumar Saxena. Dr. Ashok is a professor and the former head of pain medicine and anesthesia at University College of Medical Sciences, University of Delhi, India. He has also received IASP Global Award for Excellence in Pain Research and Management. He has nearly 200 publications in national and international journals. He's also past vice president of the Indian Society for Study of Pain. The next panelist is Dr. Abdullah Kaki. Dr. Abdullah Kaki is also professor of anesthesiology and pain medicine at King Abdulaziz University, Jeddah, Kingdom of Saudi Arabia. And he's a founder of Saudi Society of Pain Medicine. He's also member and co-founder of Pan-Arab Pain Management Union. Sorry, Pan-Arab Pain Management Union. So third panelist is Dr. Caroline Haylock. Dr. Caroline is a consultant anesthetist, intensivist, and the pain physician. She is currently working at San Pedro Sula, Honduras. She's a director of programs of the WFSA and chair of the Diversity, Equity, and Inclusion Committee at WFSA. And the fourth one, the last one, panelist, Dr. Khalilullah Shibli. Dr. Khalilullah is a senior consultant, anesthetist and a pain physician at Hamad Medical Corporation, Qatar. He's also the program director for the anesthesia training there. And previously, he has been heading the pain fellowship program in the same hospital. So we will begin our discussion with the Dr. Ashok. So Dr. Ashok, the first question for you. Cancer pain is rarely untreated, unrelieved. What does the stats say about it? Dr. Ashok, can you hear me?
Yeah, thank you so much. Thanks very much indeed, Dr. Ateeq, for your warm introduction. Sorry, my video is not working, but I'll definitely go ahead with the this thing. Thanks for the opportunity. Well, cancer pain, I'm sure everyone in the audience knows that it is one of the most complex and a prevalent symptom in the cancer population. We all know that. And despite the protective role of acute cancer-related pain, it is also an important predictor, we all know, for the likelihood of the development of chronic pain after the cancer treatment. That's a very unfortunate part. Now, if you're asking me the stats, if I go with the systematic review and meta-analysis, a very recent one published in March 2022 in the Journal of Pain Symptom and Management, this was by Evan Poyle et al. They have pooled a lot of studies. Ultimately, they narrowed down to 12 studies, which included 10 studies on the breast cancer and 2 studies on the lung cancer. Now, the figure that comes up in the meta-analysis for the pooled pain prevalence rate during the cancer treatment, this was 40%. I'm saying that it was 40% with a 95% confidence interval of 0.29 to 0.51. But with a high degree of heterogeneity, which was 96%, I'm sure that means you need a lot of more data and you need more research on this aspect. Now, actually, they did a meta-regression analysis, and that was performed, and that is how they concluded that it was actually, 40%. But the previous figures before 2016, all the systematic review and meta-analysis which appeared before 2016, they are revealing, the pooled pain prevalence rate of almost 55%. That means above 50%. That means somewhere you find that there has been some improvement. But whatever it is, the important part here is the authors realized that if we take a figure of 10 million cancer patients worldwide, well, yes, it may be more than that. They have predicted that increased duration of surgery and the high rate of pain catastrophizing before this cancer surgery, they were responsible for persistence of pain even after the cancer treatment. And again, the important figure here is that we need to know that why these figures are actually alarming. There is another study which appeared with the statistics, as I'm mentioning, from Germany. And that one reveals a figure of 37.9%. Again, it is close to 40% of the cancer patients who suffered from cancer pain. Now, the interesting thing here is, they found it is more in young patients, it is more in females as compared to males, it is more in unemployed cancer patients, and it is more prevalent in less educated. So, reported more severe pain in these categories, which I have just now mentioned. Now, why the incidence or prevalence of pain is less in elderly patients or very, very elderly patients is still not known. And the exact, the reason is not known. But the statistics say that it is more in young patients. And out of them, the more interesting part is that not only that they suffered from pain, they also suffered from psychological distress. That means they had very high degree of anxiety, depression, and at least 32% of cancer pain patients, I'm saying 32% of the cancer pain patients, they wanted to die. Now, if they wanted to die, that means they really suffered from and experienced a very high degree of psychological distress. So that is one aspect. And all these studies, let me tell you, even this German study, they had included almost 3,700 cancer pain patients overall. And out of them, they found that, yes, the incidence was again quite high. I quote another study from US, and this is again where they found that out of 4,526 cancer survivors, at least 1,648, that means 1,600 plus, they had chronic pain. And 768 or 700 plus patients had high impact chronic pain. Now, this is in the cancer survivors. For this, the reason quoted are almost 3-4, one of them being, the prolonged cancer surgery. The other one is chemotherapeutic agent-induced neuropathic pain, or we call it a CIMP, and then radiotherapy-induced neuropathic pain, radiotherapy-induced enteritis, radiotherapy-induced mucositis, or oral ulcers, and those kind of things are there. So various reasons have been mentioned, but the point is that yes, the incidence happens to be quite high. So having quoted these figures from US and having quoted the figure from systematic review and meta-analysis, we find that yes, overall, I'm so sorry to say that from I could not retrieve any study, maybe although I tried my level best, from the Asian continent. Even from my country, India, I could not retrieve any study on the prevalence of cancer pain. There are studies on the prevalence of chronic pain, but not on the prevalence of cancer pain during treatment and cancer pain after treatment. So that's the data which I thought I must submit. But another thing which I would like to add here, that if you really ask me that in advanced cancer, and especially the bone cancers and the metastatic cancer, obviously the figure is very high. It is going to be almost 69%, 64% reported in patients who are in advanced systemic, the terminal stages. And the most unfortunate part is that at least 69% of these cancer pain patients, I'm saying, or say take it as 70% of these cancer pain patients, they restrict their daily life activities. What an unfortunate thing. They cannot do their daily course, and they find, and of course this is overall, because things may vary. Like if I talk of prostate cancer, the negative impact on pain on the overall survival has been very well established and demonstrated. So certain cancers, the negative impact of the cancer pain on the overall survival is very well established, and prostate cancer is one of them. So pain, in my opinion, and I'm sure everyone would agree, that pain can always be taken as a prognostic factor for a shorter survival. And as our learned speaker, Dr. Eric and Dr. Ateeq, all of you, and Dr. Gauhar, all of you will agree that yes, we agree that yes, cancer pain is absolutely untreated, unrelieved, and the stats say that yes, the figures are quite high. So I hope I have not exceeded my time. Thank you so much.
Thank you, Dr. Saxena. I'm grossly aware, like it's really untreated, but the facts you have quoted, that's most of them I came to know first time. But anything in relation to the low middle income countries you can quote here. I know you already have said you don't have any data in relation to India, but anything in relation to other part of the developing world.
Well, I can talk about my own country. I can talk about India itself, and I tell you that the figures are quite high. I tell you the figures, though not yet published, but in our experience and in the communication and discussions with our colleagues, the cancer pain prevalence remains as high as almost 70 to 80%. You will be shocked. It is almost 70 to 80%. The prevalence rate is here, and despite our best effort, but obviously, we are working in those metro cities and those main cities, But when we talk of the rural world, the figures are quite high, unimaginable. So at least I can talk about my country that the prevalence is quite high, despite our best effort about the creating an awareness, but then it remains high. It remains high.
Thank you. Before I move to the next question for Dr. Saxena, just for the audience, they can leave question or a comment in Q&A section there. You can see on the bottom there. So we can discuss your comments or the questions if we have time at the end of this panel discussion. So why it has left unrelieved, Dr. Saxena? You have a lot of physicians like me, every part of the world, and they're working on every kind of disease. So pain is the kind of thing like comes in the vital signs. So why it has left untreated?
Absolutely, absolutely. You see, the point here is that, of course, Dr. Eric has highlighted so many factors. The thing remains that, I mean, what should I say? In the sense that the awareness and the pain education amongst our clinicians is actually lacking. And I would rather, name them as potential barriers, potential barriers to effective control of cancer-related pain and why it is left unrelieved. If my perception allows me, I can divide it into two. One is patient-related factors and the other one is physician-related factors. I would first talk about the physician-related factors, if you permit me. Well, obviously, there is inadequate pain assessment. Even many of the best clinicians, they really don't know how to actually assess pain, the severity of pain. Forget the neuropathic component, even the nociceptive part, they are not able to, they are not even, whether you say they are not aware of the NRS scale or numeric rating scale, or for lack of time or in their busy practice, but they are not doing it. So one is the inadequate pain assessment, right? The second one happens to be discrepancy in healthcare providers, right? When I talk of patient assessment of pain. And I already said lack of knowledge about pain assessment. Our physicians, if we start telling them, well, this particular neuropathic pain symptom inventory or DN4 questionnaire or PDQ or pain detect questionnaire, they are also important, in addition to NRS. Maybe some of them, they agree and some of them start practicing, but not all of them. So lack of knowledge. Then distraction by cancer treatment. I should not say that, but then I mean, like, our clinicians get so much focused and so much busy, with the, say, whether it is chemotherapy or radiotherapy or with the surgical part, that they forget that yes, pain is also something which is important to be treated, as highlighted by Dr. Eric. Then concerns about, of course, the last but not the least, Dr. Eric has already mentioned concerns about the addiction part, right? Or the tolerance, or say overestimation of the potential risk, as they say, the addiction and those kind of things. And last but not the least is lack of availability of qualified pain specialists. That is also a very important point. I'm sure all of you will agree with me. So this was regarding the physician-related factors. The second one, which I categorize as patient-related factors, where there is denial, or I can say a failure to report pain. Now, why there is denial or failure to report pain? We name it as stoicism or fatalism. Fatalism about their disease. They are so frustrated. Then they have concern that pain indicates disease progression. They are concerned, but they don't
Can
want
I
to
interrupt you, Dr. Saxen? I think so. The same question I have for Dr. Kaki. So
okay. No, you're right.
Okay.
You're right. There may be a lot of overlapping.
Thank you very much. Thank you.
Thank you so much.
Dr. Abdullah Kaki. So I have a question for you. Like, who is responsible for all this misery?
Okay, thank you, Dr. Ateeq. As you heard from Eric and from Ashok, they covered most of that, but I will try to touch it from a different point, actually. If we started with those working in the medical service, we will notice that there's a significant lack of knowledge among them regarding pain, types of pain. A lot of the doctors, they don't differentiate between neuropathic pain and nociceptive pain or nociplastic pain. And this is an issue because they don't prescribe the proper treatment. And some of them, they're only trained to give pharmaceutical medication, while others, they're only trained to do interventional things. And we need a multidisciplinary, multimodality. So this is a problem dealing with cancer pain, actually. And we have a problem in the pain assessment. Since 1987, we always say pain is the fifth vital sign, but it's not important to record it, is what to do after that. The pain is 8 out of 10. So what? What we're going to do for that? This is not well trained. None of the medical staff, whether nurses, doctors, pharmacists, physiotherapists, whatever, they don't appreciate. Yeah, it's recorded. We know that he's in pain, but give him a painkiller. If that's the only thing, pain is only physical. No, it has a psychological, it has a social, it has other component that we have to consider when we treat pain. And this is an important thing that it's lacking in our medical field. Let me give you an example. In 2017, a study conducted among oncologists, and they are the first one coming in line in the treatment of cancer. They found asking them how many hours in your curriculum spent studying pain. And the interesting thing that the average was 1.3 hours. Just imagine. So there's a significant lack in knowledge there. Of course, there's fear from opioid and the prescription of opioid, pushing the patient toward addiction and dependence. The side effect, he might stop breathing. I'm unfamiliar with this association. That's another issue there. And if we move to the patient and the family, as you heard from the others, most of the patients consider pain as a normal part of cancer. They have to accept it and live with it. And this is a very bad thing. They don't know they're right. They don't know that there's a possible treatment for this pain. Some of them, they fear, they are afraid that the minute you prescribe opioid to them, this means it's a certificate of death, because opioid is given to them when they are approaching their end of life. And this is an issue, actually. I have noticed that a good number of the patient, you prescribe opioid and they are terminal with pancreatic cancer, their lifespan or prognosis is so bad and they live for 2-3 years. So opioid is not the killer here, but they're afraid of that. They're afraid from the side effect. The family, sometimes they are worried about the patient more than the patient. Some of the patients, they are coming from a low income country, poor. They came to you in a very advanced stage. They are suffered for years before they show up in your clinic. And that's another issue here. And we have to increase the awareness among patients and society regarding this, actually. The screening, even in high income country, they don't go for screening. If you ask the lady for a mammogram or a man for colonoscopy or prostate, they don't do that, either for insurance problem or for other things, keep them busy, So this is another issue we have to keep in mind and work on it if we want to solve the problem. In the third hand, the organization, the government, the society, the association, all this also are blamed for this misery, because we don't have some sort of cooperation between us. This is an attempt to develop this link between us and palliative, which is a great thing, but we want it between countries, we want it between different societies. There's no need to invent the wheel. Those from low income and middle income country, they lack the legislation, they lack the regulation, so they can get it from there. Of course, there's a lot of obstacle here because a lot of fear from opioid addiction, and I have to put 3 lines between that. The government, they are so worried, and as we heard from Eric, that opioid, the minute you prescribe it, you encourage the opioid addiction and dependence. No, we make the regulation and the laws to facilitate the delivery of opioid to those who need opioid and prevent abuse of opioid. We are not encouraging the spread of opioid. And on the other hand, also, a lot of governmental sectors, pain is not a priority for them. In the low income, the priority is to get rid of this infectious disease that's killing millions. And unfortunately, those are suffering from pain. So pain is a priority for the patient, but if it's not important for the government or for the organization, it's important for the patient. And we have to consider that as a first right for the patient. I don't want to take a lot of time, but finally, there's a lack of statistic among low and middle income countries. We lack that, so we cannot plan our future. And at the same time, research is not supported. So we don't know where we are. Besides that, pain evidence-based medicine in pain is not that well developed, but in cancer also is significantly deficient. I hope that I answered that question. I try to keep the point limited to those.
So one point between, as you have mentioned, and Dr. Saxena, is the lack of education among the physicians or healthcare workers about the pain. How can we rectify this situation, like the lack of education?
Okay, this is a complicated problem that we need to involve all the sectors here: the government, the medical school, the United Nations, the World Health Organization, the WFSA, and others. Because here, in a interesting study, one done in Canada, I think it was in 2008, they asked the different medical schools about the number of hours spent on pain in their undergraduate. And I can assure you that it was ranging from 8 to 23 hours in the bachelor degree. In a similar study done by a British group, they found a similar finding. The interesting thing that our colleague looking after animals, treating them, they spent 123 hours in their curriculum looking after pain among animals. So we are deficient in that. So we have to work on that. We have to initiate some sort of a campaign to introduce pain management in undergraduate. And I insist on that, not only for medical doctor, but for medical, for nursing, for pharmacists, for all those involved in the treatment of the patient. Because if anyone gets something, he will remind it by others.
Thank you, Dr. Abdullah Kaki. Dr. Caroline Haylock, as you are program director for the WFSA, so I just want to ask you the role of professional organization to help with the situation.
Thank you very much for the opportunity. As we can see in a different professional organization, there's a growing awareness of the need for better management of cancer patients, greater alleviation of their suffering, but still the need of constant research into curative and palliative alternatives. And also, well, a lot of governments have initiatives to cover the deficiency, though much remains to be done. Certain organizations such as the WHO, the World Bank, and also professional organizations as the European Society for Medical Oncology, ESMO, or the American Society of Clinical Oncology, ASCO, or the Global CAN, or the International Association for the Studies of Pain, each one contributing with their bit, sometimes not so bit, to improve the quality of life and care of cancer patients. And on the other hand, the World Federation of Societies of Anesthesiologists, WFSA, aware of the struggle and the enormous need, resolved the annual theme, Anesthesia and Cancer Care for 2023, highlighting the crucial role of the anesthesiologist in the management of a cancer patient, who at some point will be subjected to surgeries or painful diagnostic therapeutic procedures outside the operating room, and who need the expertise of a physician and a specialist in anesthesiology for comprehensive and safe management of the pain and other vital functions during the procedure and also in the postoperative. This topic has become so relevant that there's already in some countries a high specialty named onco-anesthesiology or onco-anesthesia as a second fellowship. So it's interesting so that we can see that one of the main pillars of all these organizations to help bridge the gap is education. And well, this webinar here is the proof. Thank you.
Thank you, Dr. Loor. I think so the next question, we have already talked about it. That's for the role of pain education among healthcare professionals to reduce the incidence of unrelieved cancer pain. If you want to say a few words about it, as Dr. Saxen and Dr. Kaki already has mentioned a lot, but a few words if you want to say, very welcome.
Yes, thank you very much. Yes, previous panelists talked about it. And we can see that since before the year 2000, it has been struggling to declare pain relief as a fundamental human right. The United Nations Committee on Economic, Social, and Cultural Rights in 2000 identify a number of core obligations that countries must fulfill irrespective of their resources. And they include obligation to ensure access not only to health facilities, goods, and services on a non-discriminatory basis, and to provide essential medicines as defined by WHO, to adopt and implement a national public health strategy. But also the committee enumerated obligations of comparable priority, which include providing education and access to health information to the community and appropriate training for health personnel. These requirements mean that countries should fulfill each of these elements in terms of pain management. With the Montreal Declaration 2011 announcing that pain relief as a fundamental human right, we have a tipping point. When an entity is given this fundamental human right profile, it immediately carries with it certain obligations for all governments and organizations. And one of these is to provide education to healthcare workers. As Dr. Eric said, the principles of human rights dictate the pain management be an integral component of universal health coverage and a critical objective of the World Health Organization. And with the World Health Organization Assembly Resolution 67.19 stating it is an ethical duty of healthcare professionals to alleviate pain and suffering, it is clear enough the need to train healthcare workforce because we all share responsibility for alleviating pain. It is 70% of medical consultation primary care, and that's pain. This means we must continue training the healthcare workers. Education in pain in two ways, not for the community and for training health personnel on pain management. And there's a global need to speak the same language for pain management, like one system as it is for trauma. We know little about how to manage pain with a systematic approach, starting from the basics, as the previous panelist said. You know, we have poor or non-formal education in pain in our med school, nursing school, and more or less the same as scenario for residency training programs. And sometimes you don't need much for relieving pain and suffering. The WFSA, we have this resource called Essential Pain Management, EPM program, which teaches participants to recognize, assess, and treat pain in a better way, and how to overcome barriers to this management in the workplace. EPM also teaches how to teach others essential pain management. And also the World Congress of Anesthesia for 2024 in Singapore, you know, in the same track for education, we will have a workshop about cancer and anesthesia and cancer care, and also sessions about cancer and perioperative care. So we are betting more for education in this aspect. And obviously, there's still a long, long way to go regarding education in pain. We need to join efforts with other organizations and associations and together to provide integrative measures and better alternatives in pain relief and care for our patients. Thank you.
Thank you, Dr. Loor. I think so that's a very right statement. We need a joint effort between the government and the professional organization to treat this misery. So Dr. Khalil Shibli, thank you for waiting. So the questions I do have for you, they are pretty practical. What the pain physicians can do on ground to relieve this misery?
Thank you very much. Can you hear me, please, everybody?
We can.
Yes.
Yeah, okay, thank you. Thanks for inviting me for this session. Your first question is about the role of pain physicians. Now, much has been said actually, and if I can draw conclusions from the discussion happened so far, is the role of pain physicians is the role actually in public domain and in the knowledge of the public. If you jump onto without looking at the linear model of the pain management, straight away into the palliative care on oncologist, that looks as if you are at the end of the road. So it's always the pain physicians who starts treating. So the distinction starts very late in the eyes of the world, in the eyes of the pain management world, in the eyes of the patient. Even if it is presented with the pain to the oncologist, refer back to the pain physicians. So currently, because of the availability of the pain physicians worldwide, if we say they are available, first of all, there is this obviously scarcity. So the role of pain physicians cannot be ruled out. And if I refer back to Prof. Crocker's discussion that when we require interventions, when we reach interventions, then we need pain physicians who can perform sympathetic blocks and other things to relieve pain. So even in prescribing, only 14% pain relief is prescribed by the oncologist, and that goes through the ladder. So when you reach the stage of the opioid, including the opioids and the adjuvants and the advanced drugs, it's always a pain physician that comes in. Oncologist is about 14%, I read here, at the pain clinic physicians is the 63%, they reach the level of the opioids. There is a reluctance amongst the oncologists, or they do not want to prescribe opioids straight away to the pain, to the cancer patients. So that is but very precisely, I think there is a role, and that pain physician's role has to be augmented with more involvement of the oncologist, going back and forth, and the information to the patient about the availability of the options. So if I see the slide from Prof. Crockers, it says intervention, medicine, equipment, moral support, services, and standard operating procedures. So this is a very important 5 or 6 points he presented in his slides. So I probably leave it there for the first question, that role of pain physicians must be integrated with the linear model of where we are reaching into the unrelieved pain, or the pain not managed by the oncologist, and oncologists are referring back to the pain physicians for procedures, interventions, and prescription of the high-end medications, if we go back to the WHO letter of the pain management. So that's for the first question. Thank you.
Thank you, Dr. Shibli. I think the part Dr. Eric has mentioned about the intervention, that's a very small percentage of the patients that we're gonna need. So if you look at the pyramid model suggested by the US Agency for the Healthcare Research, that how many patients do need intervention, it's less than 5%. So the role of anesthesiologist or interventionalist is limited, though it's for the patients who are actually suffering from the severe pain. So I do agree with you, like it does start from the first interaction of the patient with the oncologist, and it's basically a teamwork. So by this, I will move to my next question. USA opioid crisis has worsened the incidence of unrelieved cancer pain and its impact on the opioid prescription.
Yeah, okay. I think this is exactly where I was coming at from my previous very brief description. By intervention is not necessarily the intervention which are the procedural interventions. Interventions include education as well. Interventions include all the education and all the support, biopsychosocial support given by the pain model. If the palliative care models are not very evolved in that particular part of the world. So going back to the USA opioid, it's the universal actually, it's not the universal, it's not the USA only. And this is where the pain physicians comes in. Having worked in Asia Pacific region, I worked in Singapore for 5-6 years, and now I'm in the Middle East, being trained in Pakistan and United Kingdom and the European model. So if I conclude from all those models, the opioid prescription is a worldwide issue. In 2016, there was a CDC report published. And interestingly enough, that report actually was not related to the cancer pain or cancer use of the opioids. It was the non-cancer chronic pain opioid. And that overshadowed everything. And that's how people drawn some conclusions from that CDC 2016 report, that opioid overuse, deaths, and there was a gagging policies afterwards, and then the opioid must not be used, it's dangerous, it's addictive, and all that. And that was not related to the cancer pain. The fear of addiction was never and should never have been the issue of the dying patient or patient who are requiring palliative care or who are requiring pain relief at the end of the life to improve their quality or the functionality. So they should not have been the case, but it happened. So after this 2016, there was another big data. I think Prof. Crocker's report mentioned that 2007 and up to 2017. And suddenly the insurers, the pharmacists, the policymakers, they all came into action and they start to gag. And due to that, opioid prescribing in the palliative care suffered. And it reduced in the United States because the statistics is available there. That's why we're talking about the United States. And those areas suffered and the prescribing suffered. The regulators asked not to prescribe the opioids. And the palliative care patients or the cancer patients were forced to go to ED, emergency departments, to get the pain relief. And this is where the problem started. Inadequate pain relief, unrelieved cancer pain is all being highlighted from that. However, if you look at the patient perspective, if they don't receive a prescription on time, and there is a lot of bureaucratic issues involved in their prescription, then they go to the ED and they get the pain relief. So actual prescribing in the United States have gone down, and the presentation of those patients to the ED has increased. That is the case in a nutshell. And that's for the time being. So opioid, due to the non-cancer pain, got badly repeated, and then finally the cancer patients suffer, or cancer pain became unrelieved. That's just in a nutshell.
Yeah, it does have affected the cancer pain as well, like mainly it was non-cancer.
Yes.
The last question, I will combine it with the question from the audience as well. So opioid availability and palliative care situation in developing part of the world, and also what are the alternatives for the low middle income countries to the opioids?
Now, this is very important. If we link all those questions, where the pain physicians are, where the medicines are, if you, again, Lancet Commission's report and Prof. Crocker's, I want to draw from this map that where is most of the opioid is going. It's in Canada, it's in United States, and it's all regulated. And like maybe 1 milligram or 0.5 milligram per patient is to the rest of the world, actually. You look at it. Now, one thing is very important to understand here, it's not a medical issue. We are working in a complex adaptive systems, which is the healthcare system. Secondly, we are the people processing scientists, or people processing physicians, or people processing people, basically. If you look at the product industry, they make machines, they make equipment, they make perhaps medications. They're not directly, or we're not directly involved with them. We are directly involved with the people here. And we are the ones who suffer from the emotions, from the impact. And there is nobody here to look at the palliative care's physicians or chronic pain physicians who are unable to prescribe, unable to treat their patients effectively. And day in, day out, they see the unrelieved pain and suffering, and there is no meaning to that suffering. And they need counseling. They need to be able to, other people have to understand that how much suffering whether it's in LMIC or the advanced world. Advanced world have two things in addition, which is they can educate, they can prevent, they can cure. But according to the literature, and it's a known fact that LMICs or the other countries, we do not have all those facilities, even starting from spreading the education, let alone the interventions, let alone the opioid availability, let alone all those drugs. So we go back to our biopsychosocial model, the moral support, the educating the patients, trying to educate the authorities. So it's a political issue globally because we are on the world platform here. It's an economic issue, it's an environmental issue. It's not necessarily an issue of a medical discipline or a pain discipline per se. So we can build on it if there are some questions on that one, why it's happening. But it is happening, that's the fact. If you look at the LMICs, they're struggling with the burden of disease in the cardiovascular, say for example, system. And it's the literature, I'm not saying it, it's the literature says it. They have got other health problems, lung diseases, other diseases. So forget about all those high-end treatment and how high-end in diagnostic procedures to allow us to detect the cancer early, allow us to detect things. And the distribution of the burden of the disease is such that in LMICs, I was looking at the literature, the whole report on the LMIC's chronic cancer pain is with the cigarette smoking, with the lung cancer. It's not about the breast cancer. It's about the putting a gag on the smoking and educate about the smoking and putting taxation on the smoking. It's all the whole world. But we see end of the disease, not the part where we can prevent and cure the diseases. So this is global. This is in LMICs and in other countries as well, unfortunately.
Thank you, Dr. Shibli.
Thank you.
So I have a few questions from the audience. I think so. One is relevant to you that you have already mentioned a little bit about it. How to handle the fear of addiction in cancer patients?
Now, if you're directing this to me, I think this is a huge problem. Again, I go back to the literature, why the opioids got such a bad repute. And it's all the prescription, or most of the prescriptions from the chronic pain or inappropriate management of pain, through the opioid as the mainstay of the treatment in chronic non-cancer pain. This is how the opioid got disreputed. And it's the experience and everybody's experience, and then the addiction comes from there. How many times have you actually heard, yes, indeed, the family, as soon as you start prescribing to a cancer patient some opioids or that advanced level drugs, they always ask, oh, is he going to be addicted or not? And how long is it going to be? They do not look at the comfort of the patient or the fine tuning of the opioid prescription or management for their cancer pain. They immediately look at the fear of addiction. There is hardly any report about the addiction related to the cancer pain. It's always the comfort level. It's always you want to provide them and you can fine tune them, manage them. Even with this very high doses, there was no addiction. The severity of the pain is such that you cannot make patients suffer with the chronic pain without prescribing the opioids. It's just the chronic pain patients you need to be very careful, actually. That's how I can see it. So I don't see addiction as a huge problem, and the literature doesn't support it as well. I can tell you that. As for the cancer patients or the palliative care patients, they need to be treated humanely. They need to be treated with fine management with the opioids, fine prescriptions, and allay their anxiety, families' anxiety about the fear of addiction. And obviously, the controlled drugs have to be controlled by the physicians and should be regulated. That's another thing. So I'm not talking about the free prescribing. I'm talking about the controlled management, but do not deprive cancer patients from the opioids. Thank you.
Thank you, Dr. Shibli. Another question from the audience for you, Dr. Carolina Loor. What practical steps could be taken to increase the level of awareness of cancer pain in low middle income countries?
Thank you. As we said, like a roadmap that should be bring more awareness of what's going on and all the statistics we already have. And so like these type of webinars and education and all these initiatives that we are doing worldwide, that should be part of the first step. And of course, as other panelists said, we are lacking, especially in low and middle income countries, of statistics. So these research initiatives or research efforts should be done, especially if we can, like by regions. I know we have several series of studies from low middle income countries, but there's still low percentage of statistics and studies compared to high income countries. And that's where the most of the people is suffering, and lack of opioids or poor access to opioids and other alternatives for pain relief. So I must say that education is one of the main pillars for like having it as a goal. And in that track, we can have, where awareness, writing chapters, and also getting into research more for bringing this awareness and more education. Thank you.
Thank you, Dr. Loor. So Dr. Abdullah Kaki, very interesting question for you here from the audience, the role of artificial intelligence in pain management. So I don't know how you fit it for the cancer pain.
Yeah, I think our experience with the artificial intelligence during the corona, it was great. And I think we have to continue doing that. We could utilize that for education. You know, the social media is a good source of education for the patient. Unfortunately, of course, we cannot provide it to those poor countries where there's no social media or artificial intelligence. But we have to initiate that. That's one way to educate the population, educate the medical staff, whether doctor, nurses, or pharmacists. Another way is to follow up on the patient, because some patients, they come to you from rural area. It's so far for them to come back to see you, especially with a limited number of pain doctor. Then in that case, you could follow up the patient through the through the artificial intelligence as well. So education is another way, is one way. And one form of education is to educate the patient how to assess his pain and how to do certain, I started that with some of my patients, the physiotherapy, and they think exercise. So that's another way to utilize it also. And with time, we'll get some more and more form.
I think so. That's a very tricky question. So any other panelists want to add like to artificial intelligence and the pain management?
Dr. Ateeq, can I say something?
Please, sir.
Yeah, the issue of artificial intelligence, which is now coming in vogue now in everywhere. Now I'm going back to the basics. Actually, again, I say it's the people processing issues. What are the modifiable factors politically or administratively, or arranging the quota of the opioids, influencing the governments and the worldwide, that please provide enough quota for the country? It's not by me, it's not, it's maybe through the agencies and the organizations, but I don't see it happening very soon, or it can happen, or I can modify it. One suggestion I would like to make here, having worked in so many systems, I tell you, there are support systems and there are services. Please make a distinction in these two things. The Western world or the high income world, they have services. They have services of all sorts. In biopsychosocial model, they have all sorts of inputs there. In LMICs, actually, we have support systems. We do not look at the support system, and the support system comes with the patient. You have a patient, you have a person who's accompanying, you have a family, you have relatives. If you see that they are interfering, you can modify their role in providing the support. And that support can be like not necessarily official, but that support system is a huge system. It's a cultural and social. If it is a cultural and social issue, then obviously they can influence that part of the pain. We always dwell on services. We do not have services. We do not have such things in place as if in the high income group things. I have seen services, a patient without any relative or without any social support. In our systems and LMICs, subcontinents, Asia Pacific regions, in Arab world, we have support systems, and the support system is a family system, but we do not recognize that as an important one. We think it's just something which is happening and which is probably interfering. Just turn the interference into a positive role and include that support. So just a small distinction between the support and the service. If we cry, there are no services, we will continue to cry. We will not, it is beyond us to create services. However, we can enjoy and maybe do a research, maybe do some audits, maybe get the family support, the extended family support, social support involved, and social organizations working as a charitable organizations into it. It's just the concept we need to make it clear.
Dr.
That's my
Ateeq,
2 cents on it.
Dr. Ateeq, can I have a small?
Yes, Dr. Ashok, please go ahead.
Yeah. Just wanted to add something on the artificial intelligence, because we have started.
I have another question for you anyways.
Oh, no problem. Just a small comment, that because we have started some work in collaboration with, the Indian Institute of Technology, what I feel is that AI may improve the pain outcome while effectively rationing the clinician time. Now, why I say that? Because, the artificial intelligence driven pain treatment, it becomes increasingly effective or may become increasingly effective as it interacts with the patient. There are reward points. Number of times you may interact with them 100 times, 1,000 times, 5,000 times, and then there are reward times are there. Now, one of the things which we have started at our center is the artificial intelligence driven, I would say artificial intelligence driven cognitive behavioral therapy for chronic pain. I'm not talking of cancer pain. Some of those patients are for cancer pain also, but there are non-malignant pain also. And we experience, more patient interaction, and we have experienced good outcome. So what I mean to say is that artificial intelligence, this is only one small aspect. There are artificial intelligence supported psychotherapy, you can say, or artificial intelligence programmed cognitive behavioral therapy. This may increase its effectiveness, well, again, through patient interaction. So that is why you get the feedback and accordingly you start acting. So it is something like that, very small step in that direction. Thank you so much. Thank you.
Thank you. It seems Dr. Eric want to add on something on this AI.
Yeah.
Yes, thank you. I wanted to make, if I could, a couple of points related to the wonderful comments by the panel. First, about training. Yes, training is necessary. Training in pain relief and palliative care needs to be a requirement for all medical students, nursing students, pharmacy students. But to do that, there needs to be policies. There needs to be the Ministry of Health, governmental policies that require this education in all public and private medical nursing pharmacy schools. But there's another very important issue with training. I have been doing training for many decades and have found that many of our trainees are not able to use what they learn. So if there are not also policies that require that cancer centers have palliative care services, have anesthesia pain services, then and that also enable oncologists, just general physicians, primary care physicians, to prescribe opioids according to national guidelines. If there are not the policies that enable the prescribing without fear, that make sure that the opioids are accessible in pharmacies near to where patients live, with precautions to avoid diversion and illegal use. If these policies are not in place, nothing will happen, or not much will happen. We can have lots of webinars, but the policies have to be there. So it's very important for governments, for there to be advocacy, and for governments to be made to understand that there is a financial benefit to treating cancer pain and providing palliative care, because we have data that show there are better patient outcomes, better quality of life, and financial risk protection for families, and most importantly for most governments, reduced costs for the healthcare system, because patients can get pain relief in the community in lower levels, and they don't go back to overcrowded, expensive cancer centers and referral hospitals. The Declaration of Astana of 2018 from WHO specifically states that palliative care is part of primary health care. Most cancer pain can be dealt with by lower levels. It doesn't require the specialists at higher levels. A comment about the fear of opioids and fear of addiction. It's not just that, as was very correctly pointed out, that opioids were being used for chronic non-malignant pain. That is true, and that is partly due to the fact that in the United States, healthcare has become a business, and the pharmaceutical industry gives massive amounts of money to politicians for their campaigns. So the restrictions on big pharmaceutical companies are minimized. But there's also a much longer history of opioids being used as a tool of colonial oppression, really. The British government used opioids to fund the taxation on opioids pushed onto China, the French, the same in Indochina, to help financially support their colonial regimes. And so there's a lot of antipathy to opioids. And also then when Europeans found out that opioids had all these side effects, they wrote laws that drastically limited access to opioids, and those were included in all of the European colonies. So there's this long history of laws to minimize access to opioids and to create antipathy to opioids. It's important that we be explicit about that and explain that, yes, there's this terrible history, but opioids addiction is not an issue for most cancer patients. It's irrelevant, but most importantly, there needs to be the policy basis for the education and for the trainees or doctors or nurses or pharmacists to be able to use what they learn. So last point, I'm absolutely thrilled to be part of this wonderful meeting with the World Federation of Societies of Anesthesiologists. There's also a World Alliance of Hospice and Palliative Care Associations, and it would be wonderful to pool our limited political powers to lobby governments along with WHO to do the right thing and fulfill the human rights of cancer patients and make sure they have access to the pain relief that they should have. Thank you.
Thank you very much. Thank you to all the panelists. And I'm very grateful to all the audience from the whole of the world. They're very actively involved and we have a number of questions, but as we are short of time, so we couldn't take all the questions. So for closing remarks, I will hand over the session to Dr. Gauhar Afshan. Thank you again.
Thank you very much, Ateeq. Another very, very informative panel discussion. And I have a lot of questions in the question and answer chat box, but somehow because of time constraint, I choose some of them which is interested for everyone. But certainly in future, because we is a series of cancer webinars, so maybe we'll touch upon some of the ideas which was thrown in this chat box, and we will do that. So I think for closing session, for closing comments, I would request Clare to just say some comments.
So yes, well, thank you, Gauhar. Thank you for everyone. Just on that very specific point, Eric, I'll reach out to you afterwards and we'll have some discussion about collaborating with our two organizations, because I think that would be really helpful to get some people involved in that discussion. But thank you very much to everybody who's attended the session. I hope you've enjoyed it. Please publicize it to your colleagues because it will be available afterwards on the WFSA YouTube channel in both English and Spanish. But thank you for attending and I hope you all enjoyed it. Thank you, of course, to our speakers and panelists for this fascinating discussion. We could, of course, have gone on much longer, but hopefully it will spark some more conversations to be continued. Of course, thanks to Gauhar for organising the whole of the session. And of course, we're very grateful to Sophie and to Christine and the rest of the team at the WFSA for giving up their time today, especially at the weekend, and for all the fantastic organisation of the event. As I said, the webinar will be available afterwards, and we'll also be sending you a request for feedback, just a very brief couple of questions, and we'll send you an email confirming that you have attended. So thank you again, and do enjoy the rest of the weekend.